Thank you for attending. This presentation will be fairly quick. It's about asymptomatic hypertension. You'll notice that there's not a whole lot of stuff here that's new. Most of what is here is just restructuring how we're actually managing these things. So hang tight, and this will be over in about 10 minutes. These are the folks who actually developed this content. All I did was rearrange it in a way that's quick and efficient for a busy floor nurse to get this education. So, asymptomatic hypertension. Not all patients with an elevated blood pressure need to be treated emergently. This is not new to us. Evidence suggests that gradually lowering blood pressure over days to weeks improves patient outcomes, particularly in highly vulnerable populations, such as the elderly. Often, treating underlying issues such as pain can have the desired result with no need to resort to blood pressure lowering medications at all. Because as you guys might know or might not know, most blood pressure medicines are on the Beers list, making them even more difficult to use in our elderly populations. Survey says aggressive treatment of hypertension can be detrimental to outcomes. Lowering the blood pressure slowly is better for long-term results. Focused assessment is indicated to validate rapid lowering of blood pressure. This would mean emergent situations, which we'll cover shortly. And of course, collaboration between nurses and physicians will ensure appropriate interventions. Shocker, shocker there, right? Routine monitoring in patients with elevated blood pressure is often sufficient. Hypertension, the numbers have changed a tiny bit. Traditionally, it was 160 over 100. They've tweaked that a bit to show 180 over 110. So please bear this in mind for your assessments. Is it a hypertensive emergency? This is determined primarily by you, the nurse, and your excellent assessment skills. In order to determine this, take a look at the core systems. We're going to look for stroke-like symptoms, we're going to look for cardiac symptoms, and we're going to look for respiratory symptoms. If your patient is hypertensive and you can answer yes to any of these items on these lists or any other that might not be here, because this is by no means an exhaustive list, it's a code met. If your patient is pregnant or postpartum, and they are hypertensive, that's automatically a code met because our obstetrics department have their own protocols for managing hypertension separate from med-surg. So spend a minute to take a look at this slide, and this will give you a general overview of what to look for. This, again, is not an exhaustive list. So let's say they're still hypertensive on assessment, but there were no emergent or stroke-like symptoms. If both of these happened, then rapid blood pressure lowering is not indicated. We're going to manage asymptomatically. At this point, we prefer the physician to enter a communication order stating that it is okay not to treat hypertension symptoms pharmacologically while utilizing asymptomatic management. This does not mean that we will not use medications, only that it must meet more stringent requirements before we do so. Some doctors will be okay with this. Most of our internal medicine docs are already on board with this. In fact, they're actually quite a bit ahead of nursing in adopting these new protocols. I can't guarantee the response you'll get from private practice physicians and outside physicians, but Kaiser Permanente is generally on board as well. Asymptomatic management, like everything else in nursing, is assessment, collaboration, and intervention. Once again, is that your shocked face? So we're going to look for underlying causes. Since it's no longer emergent, let's find out what might be causing these elevated blood pressures, and let's deal with them. Let's look at physiological. Are they in pain? That's king. If they hurt, your blood pressure is going to go up. That's one of the #1 side effects of pain is elevated blood pressure. So assess for pain, nurses. You should be doing this already. Look for positioning. Do they need to toilet? Are they hungry? Does the therapist need to come in and see them? You'd be surprised at the things that can go wrong with the body that we can't necessarily treat with medicines that could cause elevated blood pressure. Look for psychological issues. Are they agitated about something? Are they confused? Are they excited? Are they about to be discharged? Are they angry? Anything like this can cause elevated blood pressure. It's a well-known link between emotions and physiological response, right? There's nothing new here. What about pharmacological? Are they hypervolemic? If so, maybe you want to consider toning down the fluids a little bit. Here's where you would collaborate with the doctor. What if they're hypovolemic? Under rare circumstances, such as with autonomic dysreflexia in our quadriplegic patient population, you can get elevated blood pressure here too. Home meds, are they even in the system? Are they taking them like they're supposed to? More collaboration. What about withdrawal? Are they on TWA protocol? Maybe consider some Ativan. All sorts of things like this. Again, this is not an exhaustive list. So we're just going to check the boxes. Treat or address potential underlying causes for hypertension. They prefer us to do this with existing orders and protocols where possible, and then just reassess for continuing symptoms or issues. And you can collaborate with the doctor as needed if you need additional assistance, supplies, orders, whatever. And then, as always, be assessing. Intervention is not always a medicine, guys. Rapid lowering of blood pressure with medicines like labetalol and hydralazine, though common practice on the floor, is not always necessary. So look for pain and anxiety medicines. A breathing treatment, a snack, or a gas pill can do just as good a job. However, thorough assessment is the key to success in asymptomatic hypertension management. Collaboration is a great way to secure the best interventions for the situation, whether it be from a doctor, a tech, a dietitian, therapist, or even a nurse. Interventions based in collaboration and assessment will sometimes be as simple as needing to toilet or reposition. So here's the big one, guys, admissions. I know we all have issues with the way that we don't get nurse-to-nurse reports from the ER in most situations these days. However, we will still be accepting hypertensive patients to the floor, even if they're very hypertensive, as long as they are asymptomatic. They won't always put this in that little form that we look at before we accept them to the floor. You have to look at the chart, guys. Scrutinize that medical history. Look for signs that they may have underlying causes that need treatment if their blood pressure is considered hypertensive. You can look in the nurse view for this. Everything you need is in nurse view. You can find the medical history, recent labs, everything. If you need assistance figuring out if a patient is acceptable for floor admission or not, don't hesitate to contact your charge nurse, or if I am there, come talk to me. I will be happy to work through the chart with you. We'll talk about it. That's it, guys. See, I told you it was nice and quick. Make sure and come see me sometime during the week, because everybody gets a flow sheet that I've developed that goes along with this that will help you making decisions on whether or not to treat or to call code MET for these patients. And I will see you guys later.